And number 2, let's start by identifying the underlying breath sound. Is this vesicular or is this bronchial? Well, it's soft, it's low-pitched, and the last 2/3 of exhalation are absent, so this is indeed a vesicular breath sound. In addition, there are late inspiratory extra sounds. So how do we call these sounds? Well, it depends on your background. If you are from the US, you probably would call them crackles, or actually rals. Now make sure you don't call them rails, because rals is French, and that's the pronunciation. If you're from England, you probably are likely to call them crepitations. And actually, the terminology over the years has become so confusing that in 1977 was standardized, and I think it's useful for us to review it a little bit. Now, all the problems started with Laennec himself. Now, remember, Laennec was French, so what he had to do was to use a French expression to define these sounds, and he called them rals. Rals is French for rattle. Now, of course, there were rals and rals, so he had described them by using daily examples that were as weird as Laennec himself. So some rals, he described them as the whistling of little birds. Other ones, he described them as crackling of salt on a heated dish. Other ones were like the cooing of a wood pigeon. Now, the terminology didn't start very well with these kind of examples, but it got even worse when Laennec realized that at the bedside he couldn't even use the word ral, because he reminded his patients of the French expression le ral de la mort, the death rattle. Now, that is the horrible noise that people that are about to die make when they can't clear secretions anymore. And of course, didn't make his patients very happy. So Laennec realized that to avoid trouble, he needed to come out with a different expression. And at the bedside, he used the Latin equivalent of roncos. Now, that was not clearly understood by his translator, John Forbes. And when his book eventually got translated into English, the terminology became very confusing. And it grew so confusing that in 1977, a standardization was required. As a result of that, the term ral was abandoned, and crackle became its official substitute. So we should call these sounds crackles. Now, crackles are very valuable sounds. Clinically, they are very important. And they are very important because they provide a diagnosis, if you recognize them and if you time them. Now, remember, sounds of this type are so short, less than 250 milliseconds, that they have been called discontinuous, which means that they are indeed less than 250 milliseconds. This term does not refer to the length across the respiratory cycle. Crackles are therefore so short that they can't really have any musical characteristic. They are noises, but they are valuable noises, because if you can time them, you can identify the underlying disease process. Crackles are primarily inspiratory, although they can have expiratory components, but they are primarily inspiratory. And therefore, they may occur early in inspiration, in mid-inspiration, or in late inspiration. If they occur early in inspiration, they are generated by air flowing through large central bronchi. And these bronchi are covered with thin secretions, and it's this air-fluid interface and the bubbling generated by it that will lead to the production of these early inspiratory crackles. They are usually called coarse, they're low-pitched, and they're typical of bronchitis. They often clear with coughing. On the other hand, the late inspiratory crackles are generated by a different mechanism. They don't come from proximal large airways, but they come from peripheral distal airways, small bronchioli, partially collapsed by a high interstitial pressure. Therefore, there will be two pressures at the end of these bronchioli, a high central pressure and a low distal pressure. When the patient breathes in, all of a sudden, he re-expands the partially collapsed bronchioli, and that creates a sudden equalization of pressures and a pop. And it's that pop that is the crackle. So late inspiratory crackles resemble very much Velcro. They are fine, they're loud, and they're high-pitched. Now, why is there high pressure in the interstitium in late inspiratory crackles? Two major mechanisms. It's either scarring of the interstitium, pulmonary fibrosis, or there is fluid in the interstitium. And this fluid can be blood or pus or serum, as we saw before. Therefore, late inspiratory crackles are sound of either pulmonary fibrosis or pneumonia, pulmonary hemorrhage, and a lot of pulmonary edema. Now, what about mid-inspiratory crackles? Mid-inspiratory crackles are neither as low-pitched as the early inspiratory crackles, nor as high-pitched or fine as the late inspiratory crackles. They're kind of in between, and they originate in inflamed and partially dilated medium-sized bronchi. So their diagnosis is bronchiectasis. They are typical of this condition, as was described by Nath and Capel in a 1977 thorax study. Now let's go back to our sound and listen to it again. Now, what is the timing of these sounds? These sounds are late in inspiration. They are fine and high-pitched. The late inspiratory timing may be difficult to identify since the underlying breath sounds is so soft that it's not too easy to identify its onset. But indeed, if they are late inspiratory, what is the mechanism? Are they due to fibrosis, or are they due to fluid in the interstitium? Let's hear them again. Now, the answer is fibrosis. In fact, if the patient had had interstitial fluid, that fluid would have been very likely to spill into the alveoli, and the presence of alveolar fluid would have caused a bronchial breath sound. Now, this patient did not have a bronchial breath sound, had a vesicular breath sound, and that's why the diagnosis of fibrosis as a result of these late inspiratory crackles was more likely. Now, in order to approach and understand the presence of late inspiratory crackles, I would like you to refer to the algorithm which is included in your booklet. Based on the characteristics of the underlying breath sound, and based on the presence or absence of late inspiratory crackles, you'll be able to sort out the underlying etiology. This is a little bit of an oversimplification, but it's very helpful when you are interpreting breath sounds and late inspiratory crackles, and therefore we will use it for the remainder of the workshop.